Starting. All attendees are in listen-only mode.
All right, good afternoon, everyone. I'm Lorna Lucas, Senior Manager of Provider Education for the Association of Community Cancer Centers. I'm eager to introduce Ms. Niesha Griffith and Dr. Bill McGivney, our expert presenters for the third e-course of the series hosted by the Institute for Clinical Immuno-Oncology, or also known as ICLIO, who will discuss navigating the complex coverage and reimbursement issues related to immuno-oncology agents. As you may know, the ICLIO initiative focuses on preparing the multidisciplinary team for the challenges and opportunities presented by O and includes other vital resources such as newsletters, papers, scholars programs, and a national conference scheduled for October 2nd in Philadelphia, where both Niesha and Bill will join us as faculty presenters. Please visit www.accc-iclio.org to browse all of our offerings. Now for today's e-course, I'm pleased to introduce Ms. Niesha Griffith, ICLIO Advisory Committee member, and the Administrator of Oncology, Pharmacy, and Infusion Services at the Arthur G. James Cancer Hospital and Richard J. Solove Research Institute at The Ohio State University. She served in multiple leadership positions at the Medical Center for nearly 17 years, in addition to managing inpatient and outpatient clinical pharmacy services, education and research programs, and the Medication Assistance Program. Ms. Griffith is also the Director of Health Systems Pharmacy Administration Residency, holds multiple committee appointments at the Health System and the James, and lectures regularly as a Clinical Assistant Professor at the OSU College of Pharmacy. Under her tenure, the Hematology and Oncology clinical programs at the James have grown from a 2-specialty inpatient service into a program with over 20 specialty practice pharmacists covering all inpatient and outpatient disease-specific areas. Furthermore, she's overseen the expansion of the James from 2 small satellite pharmacies to 5 full-service outpatient infusion pharmacies. Ms. Griffith is a passionate advocate for providing comprehensive supportive care for cancer patients. She has testified numerous times for the Ohio State and House supporting issues aimed at improving medication safety and access for cancer patients. Additionally, I'm also pleased to introduce Dr. Bill McGivney, who is Principal at McGivney Global Advisors. Previously, Dr. McGivney was Chief Executive Officer at the National Comprehensive Cancer Network, NCCN. At NCCN, Dr. McGivney was responsible for the development of strategies and programs aimed at improving the quality of cancer care available to patients in need. Such programs include the NCCN Clinical Practice Guidelines in Oncology, the Drugs and Biologics Compendium, the Oncology Outcomes Database, Managed Care Collaborations, Oncology Research Program, and the collaboration with the National Business Group on Health. Prior to joining NCCN, Dr. McGivney worked at Aetna Health Plans as Vice President for Clinical and Coverage Policy. At Aetna, he directed several groups, including National Coverage Policy, Technology Assessment, Clinical Guidelines, Pharmacy Policy, Institute of Excellence, Transport, National Cardiac Care Network. We hope you'll join us for the ICLIO National Conference this fall, again, where Niesha and Bill will both lend their expertise. And for a few housekeeping notes, please feel free to submit questions for our webinar presenters by typing your question in the box on your dashboard. I will pose questions to the panelists at the end of the presentation, and the webinar will be archived and available on the ICLIO website by the end of the week. Now I'll send it over to Dr. McGivney to kick off the webinar.
Very good. Good afternoon, everybody on the East Coast, and good morning to those of you west of Eastern United States. So today I just want to provide basically a general environmental scan with respect to the coverage and reimbursement area with specificity, obviously, to immuno-oncology and even more so with the anti-PD-1s as examples of what's going on out there. And then as you can see from your screen, Niesha Griffith will talk really about what's happening from a real-world business perspective, practice perspective at one of the largest institutions in the United States, the Ohio State, James at the Ohio State University. So, next slide, please. And the slide after that. Great. I just want to provide a little background here very, very quickly. You know, in the good old days, I guess it was, utilization by clinicians, by doctors, prescriptions, etc., basically established what was medically accepted. And then as managed care began to establish itself very early on in the 1990s, that really changed. And many of you know the story. It changed specifically to more outcomes-oriented, evidence-based decision-making processes and programs. And obviously this gave payers more control over what was covered. And basically they set up programs to evaluate the evidence, and this led then to their coverage policies. And over the years, these evidence-based assessments have become also more cost-oriented. And it's just interesting to note that it was really in 2004, when prices actually were quite tame back then. It was 2004 that we saw basically, my screen just changed, sorry. We just saw an article by Dr. Schrag, who was then at Memorial Sloan Kettering, talking about the high price of agents used for the treatment of cancer tumor types. And indeed, this is accelerated with financial toxicity as specified by Dr. Solove and other doctors and key thought leaders like Dr. Bach at Memorial Sloan Kettering as well. Next slide, please. We're going to talk a little bit very quickly about the flow down, if you will. So an FDA-approved indication, as most of you know, generally, almost always, if not always, leads to payer coverage of that indication. That's really critical. But when we go to expanded or off-label use, and here we see certainly a field that is accelerating quickly and will go to many, many indications. When we go to expanded or off-label use, the NCCN becomes critical. And we're not going to talk too much about recommendations or preferred status specifically, but it's critical because payers basically have established processes that are based on NCCN, and their coverage processes really do flow down from the NCCN. Now, with respect to pathways, just a quick word. Clearly, commercial pathways are important, but institutional pathways, large institutions, large group practices, et cetera, are establishing their own pathways specifically. And at the end, the provider wants to make sure that the practice, that the center, that he or she indeed does get covered for the prescription of specific agents for specific indications. Next slide, please. NCCN has been critical in this. I'm not just speaking about NCCN because I was there for 15 years, but NCCN has established key processes, programs, and information products with respect to the influence of coverage. No more so than the NCCN guidelines, which were launched almost, well, actually about 20 years ago. But then one of the offshoots of the NCCN, one of the formats that the guidelines were put in, has had tremendous, obviously, influence when we're talking about drugs and biologics and coverage and utilization and prescription, and that's the Compendia. The NCCN Compendium was started in terms of development in 2005 and basically began to be released in 2007. And next slide, please. It was in 2008 on January 16th that something really critical and important happened, and that was United Healthcare put out a press release that said, basically, if it's in the NCCN Compendium and it's 1, 2A, 2B, we will pay for it. June 5th, 2008 was another important event related to the NCCN Compendium that occurred at 4:16 p.m. Not that when I was at NCCN we were watching that too closely, but CMS recognized the NCCN Compendium, and as you know, there are 3 other recognized compendia out there. What this did, looking at the bottom bullet point, was it really gave back to clinicians a substantial voice in determining what was available, especially available through coverage policy, not only recommendations about prescription or prescribing in private practice. Moving on, NCCN, as many of you know, most of you probably know, has specific categories. So we're on the next slide, please. Has specific categories, most of which are Category 2A, and they're key for coverage policy determinations and establishment of policies. Now, coverage policy is important, but just like FDA approval was when you had a big party if you were a biopharma company, coverage policy is yet one more step in the process. We have pre-authorization criteria and step therapy and a variety of other processes to go through these days. 2B is an important issue as shown on the next slide. And the 2B category, which again only represents 6% of all recommendations at NCCN, is important from the standpoint on the far right column there that some private payers, a few, not many, but an important one like Anthem/WellPoint, takes the stance that we are not going to automatically and sometimes not going to cover an oncologic agent, biologic, that has a 2B category that is attached to its recommendation from the NCCN. From the beginning, from 2008, the Medicare program indeed said that they were silent with respect to a 2B recommendation, and that they would leave it up to the Medicare administrative contractors, or on the Part D side, the Medicare Advantage plans, to make their own policies about whether or not a 2B recommendation would be covered. So that's critical. That's important, again, in terms of the lives of almost 20% of the population out there. Next slide. Quickly, just to show you, if you went online and you looked at United Healthcare and looked at their medical benefit, indeed, you would see specific wording that states that United recognizes indications 1, 2A, and 2B, both on the medical benefit side and where we are right now, obviously, with the immuno-oncologic agents out there, be it Nivolumab or be it the anti-PD-1 specifically. Next slide shows the same really pertains to the pharmacy benefit. Moving on to the next slide. See the next, yes, thank you. So indeed, there are other compendia out there, and these compendia indeed are specified by the large commercial private payers specifically, and obviously, as already mentioned, by the Medicare program as recognized compendia. Indeed, they are important, and especially drug dex addresses off-label use, but the NCCN compendium still remains the most influential in oncology, and it's the only oncology-specific compendium. But with specificity to off-label use, its importance is even greater. So let's just look real quickly on the next slide at coverage policies out there. I think one of the major issues that is going to be faced, and Niesha will address this from a real-world perspective, is the fast and accelerating pace of the development of indications for agents like Nivolumab and Pembrolizumab, and the ability of payers to keep up with the data that comes out in a variety of formats, settings, publications. And you can see that, and actually this is as of 10:30 a.m. this morning, if you go on the Aetna coverage policy and Google it, it still does not specifically recognize non-squamous non-small cell lung cancer as an indication, calls it investigational and not medically necessary. However, I think in the real world out there, everyday practice, it is generally getting covered, and Niesha will address that. Moving on to Anthem, the same thing actually pertains. That's on the next slide. And again, no specification of non-squamous non-small cell lung cancer as an appropriate indication. And I would say that, again, for Nivolumab, that indication has been in the NCCN guideline for at least 2 months or so. With respect to Pembrolizumab, obviously Anthem is up to date on that. Next slide. Interestingly, the Medicare program, just checking, say, with Wisconsin Physician Service, the Medicare, this MAC, this contractor, was the most up to date with respect to indications for Nivolumab, and I only specify Nivolumab because we are looking at the point in the issue of identification and coverage for non-squamous metastatic non-small cell lung cancer. So my final points are on the last slide, and I've made the point that with respect to coverage issues, the concerns are only going to accelerate, as we have, as shown kind of in the first sentence regarding more indications. And we know that these are coming, and actually Niesha will show you utilization at the Ohio State, at the James at the Ohio State. And then we're going to have acceleration with respect to the number of agents that are out there. The anti-PD-L1s are coming. And indeed, there'll be, and this obviously is of tremendous concern to payers, there'll be a variety of combinations specifically that will certainly garner an awful lot of attention and an awful lot of assessment activity specifically. And finally, a variety of issues. And we're not embroiled, that's too strong a word, but still the consideration of the appropriateness, the effectiveness, and the utility of overexpression of PD-L1 as a biomarker is an issue that's being discussed actively out there. So I will pause, and I will turn it over to Niesha Griffith to really examine the processes, the practices, and the issues, as I said, at the James, which I believe is the third largest cancer center in the United States with respect to the number of patients treated. So Niesha?
Hi everybody. Thanks for joining us. Thanks, Bill. Yes, we opened our new cancer tower in December, and hard to believe, knowing where we started, when I started here about 18 years ago, that we are now the third largest cancer center in the U.S. So one of my concerns is probably the concerns of many of you on the call today is what this is doing to the bottom lines of the hospital. And as much as we thought we could anticipate how our use was going to look when we originally budgeted for these agents, based on everything that we're seeing at the market, I think a lot of us probably were a little bit off the mark. At least I know that I was. Next slide. So I wanted just to go through our experience with each of the drugs, and then I'll talk a little bit about the processes that we've really put into place to help support the use of these drugs, with the ultimate goal obviously getting paid for the drug or getting a patient on one of the support programs. So for Pembro, obviously we added that to formulary as soon as it was released from the market. We haven't had as much use for the Pembrolizumab, and I'll explain a little bit more about that as we go on. To date, we've had no write-offs, but as you all know, these are still fairly new drugs, and we're working through some of the appeals and denials, and so time will tell, but we've really spent a lot of time and effort trying to avoid that. As far as the Merck programs, so far the only thing that we've been able to gain from the program was getting 2 patients on copay assistance. Primary use has been in the metastatic melanoma setting. Of interest, are one patient that we've used this on for squamous was actually the first week that the drug was on the market, and we actually had a payer that was willing to pay for it, so that was kind of a surprise out of the gate. I call these drugs game changers for a number of reasons, and one being the fact that, you know, if you think about how many times have we added drugs to formulary where we're having a request to use them off-label the first week that they're on the market. That certainly doesn't happen all the time. Next slide. For Nivolumab, we have used considerably more of that with 120 requests. Again, I say requests because some of these patients actually didn't make it to therapy for both of the drugs. We haven't had any write-offs to date either with this drug. We have had a lot of success with using the BMS program. We've had 19 patients who received the assistance with where we received drug to cover the therapy, and then also with the copay assistance. And so BMS has its own copay program and also will refer patients out for disease-based grants. A lot more indications here, and really the reason that you're seeing the difference between the two is because the original design of the support programs was really what drove us toward Nivolumab. We've recently learned of the changes in the Merck program, and so I expect that we will see some growth with using the Pembrolizumab, especially for patients who are traveling, and we can offer the option of the every 3-week dosing. But again, here primary use has been in metastatic melanoma, and then certainly quite a bit, as you might expect, in renal cell and in lung. Next slide. So I wanted just to go into a little bit. I'm not going to spend too much time because most of you that are on the call probably are pretty familiar with the programs already. When we complete these forms, we actually check all of the boxes because depending on what comes out of the patient benefit investigation, we may need support for the patient in other means. Next slide. And then here you see, as you would expect, excuse me, that we are asked to supply the ICD-9 codes, any of the previous treatments, which was especially important right out of the gate when these drugs were only being used according to the label. And then this form about the BRAF mutation. Next slide. This is an additional form that Merck has recently added, and this is really why I say I think that we'll see more uptake of the use of the Pembrolizumab. Originally with the Merck program, there really was no room at all for off-label support, even with the change, even with what we saw with NCCN, as Bill mentioned. Everything that we had sent that was off-label was being automatically denied. But they've added this attestation form, I believe is what they call it, And here you can, the physician actually is an additional form for the physician to sign, and essentially attesting to the fact that it either is NCCN or not an approved use. And I just circled there in red because I just want to bring to the point that it's not saying that the patient's not eligible for their program where they'll provide drug. It's just saying that they're not eligible for copay assistance, and I think some folks might have misinterpreted that. Obviously, no guarantee about product replacement as all the other programs. That's not something that they promote, but it certainly opens the door for the uses outside of the labeled use with this attestation form. Next slide. Again, the BMS program, we do also check all the boxes here. Here we actually are asked for a description of the diagnosis in addition to, well, obviously right now just the ICD-9 code. The one thing to note is that they do not ask about the BRAF mutation anywhere on this form. This is a shorter form. There is no attestation form required in addition to this either. Next slide. And I'm going to go into a number of these things in a little bit more in depth, but I just wanted to make the point here that we are using these support programs, and really as we do for any of our really high dollar medications for both on and off label uses. We have what we call our high dollar medication process. Through our P&T committee, pretty much we had decided anything that's greater than $50,000 for a year of therapy would go through the high dollar process. And then we do have an off-label policy, and we have algorithms for both Medicare and for the other payers. Next slide. Bill's talked a bit about the payers, but this is really just the experience that we've seen thus far with our payers. I know some of the regions, their MACs have come out with LCDs. We don't have one here yet in Ohio. For all of our off-label use right now, we are requiring the patients to sign an ABN. For managed Medicare, really all the plans that are managing these Medicare patients already have guidelines, clinical policy guidelines, many of them in line with NCCN, as Bill's already mentioned. Anytime we do not get an off-label predetermination approval, we have the patient sign a notice of non-coverage. Next slide. So for Medicaid, as you know, we can't require the patient to sign that and anything about non-coverage, and then if denied, and if we had decided to move forward with the treatment, if denied, really our only option is hoping that we can get drug through the support program. Managed Medicaid, we've seen policy guidelines, and we are using the predetermination process here, as well as having patients sign the notice of non-coverage. Next slide. And then for the big payers, obviously, as Bill had shown, clinical policy guidelines, most of them following NCCN. We are requiring the predetermination. We are requiring a signed notice on non-coverage. As you might expect, Anthem is the one that we're really seeing that has the most scrutiny, and where actually we've seen denials even after front-end predetermination authorization, that we still see the denials. Next slide. United Healthcare follows the NCC guidelines and essentially following the same process for United Healthcare as the other payers. I think the other thing that I say that has kind of been game-changing about these drugs is the number of patients who are willing to pay out of pocket. So upon signing the ABN or the notice of non-coverage, or if we have a flat-out no and we know that we probably won't be able to help the patient, they are willing to put a deposit down and pay out of pocket for these therapies. Before the NCCN guidelines, this was a lot bigger of an issue than it is now, because we've been pretty successful with getting patients on the program or the payer more willing to pay for the off-label. Next slide. So what are the challenges? I'm sure those of you on the phone, you're probably very familiar with a lot of the same ones. We had the request for the off-label use right out of the gate, essentially. And one of the things that we found disappointing, and I think Bill mentioned this, and it's not unique to these agents, but calling payers wanting to authorize these, even for the on-label indications, and they're not really prepared to answer coverage questions or render decisions. We've gotten, well, we don't have a policy on that yet, which obviously for those of us who deal with cancer patients really isn't a good answer. The support programs are different. As I mentioned, the Merck program does require an answer related to the BRAF testing. The off-label support was an issue out of the gate, but now it appears with this attestation form, from what I'm seeing on the listservs, there are folks who have been successful with getting off-label approval through the Merck program. I think it's pretty obvious based on a lot of the things that I've already said and some of the things that I'll continue to tell you is the resource intensiveness that we're putting around these drugs. With as much as they cost and as much as we're using them, we really have to make sure that we have a good infrastructure in place on the front end so that we don't have any back end issues. And so it's really been quite an effort with our whole clinical team is involved in addition to our reimbursement folks. Next slide. I thought it would be helpful just for you to get an idea of how this has affected our off-label drug use. We've been tracking this really since about 2003. We just added 3 new FTEs to help deal with this. It's really had a significant impact on the workload. Next slide. So some additional challenges. It's a communication and coordination. You know, for those of us in large organization, it's a lot for us to communicate within our organizations, let alone when you've got external parties involved with getting patients on programs and trying to get drug. I mentioned the out-of-pocket payments. You know, this was something that we did very rarely, and this really forced us to put in a more structured process for out-of-pocket, which I'll share with you in a moment. And then certainly, as I mentioned, kind of at the get-go, is the budget impact. We have a lot of off-label use right now that's driving increased usage of these drugs. We all know that there will be indications released soon, and then certainly the number of clinical trials is indicative of what's to come. I looked earlier this week, and we've got about 17 open trials with one or the other of these 2 agents. Next slide. So how we've made it work, I mentioned our high dollar process. This is not unique to these drugs again, but it's something that we feel that's important for those drugs that are adding considerable amount of money to our budget. We always use these support programs because if you want assistance after the fact, if you haven't enrolled a patient in the beginning, a lot of times they're not forgiving about that. We're fortunate. We do have disease-specific clinical specialist pharmacists at the point of care, so they help a lot, both with getting patients starting the process with the high dollar as well as getting engaged with off-label, which is the next thing I have mentioned here. We do a full predetermination, and I'll get into what that really means for our organization here in a minute, but all off-label go through the same process. We have a policy that supports the process. Patients are made aware of their risks and benefits, and part of that discussion includes the financial risk. Again, as I've mentioned earlier, we do require our patients to sign an ABN or notice on coverage, depending on what the situation is. And then we have built into the policy a peer review escalation process as well. Next slide. I mentioned we added 3 FTEs. We actually brought the reimbursement folks from our finance department into the pharmacy to handle high dollar and off-label. For the high dollars, these folks really work with the pharmacist specialists to get the information that's needed for the program application. They also will perform the pre-certification on the high dollar drug. As I mentioned, also they handle all the off-label. You know, the nice thing about bringing them over to our department and assigning them to disease-specific teams is it's really more of a collaboration rather than somebody from pharmacy speaking to just somebody in finance and not really having the opportunity to develop a relationship. But this way, our reimbursement specialists are really learning about their discipline and the drugs and the different disease states within that disease-specific group. So it really makes it more efficient and frankly, a better process. We also follow every claim to ensure payment. We are looking at these really on a daily basis to see where they are in the process. And then I'm going to share with you for both the high dollar process and off-label, the only way that we could possibly do this with as big as we are and as many people that need to be involved is to have detailed process flows that explain how it's going to work. Next slide. So this is what the high dollar process looked like. As I said, we do it whether it's on label or off label. They just go down a different path. We do have, in addition to our reimbursement folks, you'll see that we have medication assistance coordinators. So anytime we're going down the path of getting drug in, that's really where the handoff occurs with the medication assistance coordinator. They really handle anything related to the receipt and the tracking of the drug. That's a pharmacy program here in Ohio. They're pretty strict about who handles drugs, and so we decided to keep that in the pharmacy, although I know there's several models out there where it's not within the pharmacy itself. Next slide. Just to briefly mention our predetermination process, it really is a team effort. Obviously, we are involving the physicians. A lot of these forms require clinical information, which primarily the advanced practice provider or the pharmacist will help support that and get the physician's signature. One of the other really important things that we found right out of the gate when we started with our off-label policy and process is we really had to have a way to follow these claims in our system, even up front, knowing if we had the original approval. So we actually have done that with building a database. Next slide. As I said, the pharmacist is heavily involved, and they're really gathering the information and the evidence-based support to submit to our reimbursement specialist. And we do have, as I mentioned, the tracking database, and that actually triggers an email. So every time an off-label request is put into our database, I actually know about it in real time. Next slide. The reimbursement specialists, as I said, those are now embedded in the pharmacy. They're the ones who are really pulling all of the financials and putting that together with the literature. Next slide. And then they're drafting the letter of necessity, medical necessity, and sending that off to the payer. And as I said, they are really the ones who are continuing to follow the claim. Next slide. Just since I've talked about it, I thought it was worth showing what we're doing. This is just an example of a test patient in our database. This is if you just wanted to look at a specific claim, you can bring it up this way. These are the different points that we're capturing: the patient's name, the MRN, when it was submitted, a list of the off-label medications, which aren't showing in the screenshot, but we have the ability to do that, where we are in the process with the claim, who the payer is, and where we are with the submission. Next slide. And so this is the field that gets filled in by our reimbursement specialists, and this is where we can say essentially where in the process. So they have the ability to go in and change these fields as the claim moves along, and then the pharmacist or myself can log in and see where the status of the claim is. Next slide. And this is the part that really requires the pharmacists to fill in. So they are putting all the all the treatment regimen related information into the database and then checking the peer support information. So the reimbursement specialist has all that in front of them. Next slide. And again, this is just another close-up of looking at where we are in the process with any specific claim. This one we had already worked it through. Now we're just pending payment, and we'll be able to watch and fill in the amounts here. Next slide. I mentioned our peer review process. We have used this since we had the policy in place, so anything where the evidence, we don't have a lot of strong 2 phase 2, 1 phase 3, or in a peer-reviewed journal, we will use this escalation process if we have any concerns about using that specific regimen. We do look at safety, efficacy, and cost. Obviously, this isn't just about the money, although sometimes I think the pharmacists feel like they have to be the gatekeeper, but that's not what this is about. And then, as you might expect, depending on people's schedules, up to 72 hours, but it takes that long. Usually it's running in tangent to what's going on with the payer approval anyway. Next slide. I just included a copy of our algorithms. I'm not going to go through these for the sake of time, but suffice to say, if you look at the color coding at the bottom, the clinical team and the reimbursement folks are heavily engaged in all of these processes. We do have the clinical team involved in having the discussion with the patient about the financials. We think that that's really important, especially when they have questions for their physician or their advanced practice provider. Next slide. And then this is just the post-treatment for a Medicare patient. If we had someone who had already upfront agreed for payment and we knew it was likely to get denied, then we would get financial counseling involved. Next slide. With the commercial payers, I think, again, you see lots of yellow and blue here for the clinical team and the reimbursement. The one thing that's added on here, as I said, the light tan is our manufacturer assistance replacement options. That really is housed within our medication assistance program. So it's kind of like a marriage between the reimbursement specialists and the medication assistants, and they actually all report up to one manager, but they work very closely together. Next slide. And this is really, we had an off-label flow for a really long time, but this second part of the slide was really added to deal with the issue when the patient wants to pay out of pocket when we don't have a good level of confidence that we're going to be able to get it paid for, and then medication assistance and financial counseling get involved. And I believe that is my last slide, and we're ready to entertain questions.
All right, thank you again, both Niesha and Bill, for the presentation. So we do have some audience questions that I'll pose. And Niesha, the first question is for you. How are you determining if a chemo-certified nurse is needed to infuse, and how are you classifying?
So, thanks, Lorna. I wasn't sure about the second part about the classifying, but for all of our nurses that are infusing chemo, whether inpatient or outpatient, we have our own chemo certification course. That's very much mirrors the ONS course that previously existed. And so our nurses are required to go through that, and then they're observed by a chemo-competent nurse prior to them being released to doing chemo on their own. So that's a requirement for every nurse that works in our oncology clinics. And the classification, I'm not really sure. I don't know if the person who submitted that could clarify.
Okay. Well, we'll wait to see if they chime in with a clarification. So the next question, Niesha, is would you describe what you've done to ensure prior authorized drugs as well as LCD, NCD drugs have been matched to ICD-10 codes?
Obviously, we're looking at the documentation. That's still a bit of a work in progress for us, but I can tell you what we do now. We do have a reimbursement specialist pharmacist that I didn't mention. That person has a little bit of a different job than the folks that I mentioned during the presentation, and his job is to monitor all of LCDs, NCDs, and payer policies, and alert our coders and our managed care folks of any changes in the policy that are going to affect pharmacy and any of our coding. It's also been really helpful to have this individual because as new policies are released, he'll run them by our disease-specific clinical specialists, and they can take them directly to the team for feedback. We do a lot with writing to CGS, our MAC, when we see things that are missing that are common, more standard of care uses here. So we do that for both the Medicare policies, and we're now doing more of it for the commercial payers as we're seeing more and more commercial payers have their own policies.
Okay, great. All right, I think we have time for a few more questions. So again, how do you handle off-label use in clinical trials, Niesha?
Yeah, that's a challenge for sure. We're fortunate that we have a clinical scientific review committee that everything goes to for the cancer trials before it goes to IRB, and we recently created a checklist of things that the pharmacist sits. We have two pharmacists on CSRC. Checklists of things that have to be questions that have to be answered and things that have to be dealt with before it can go on to IRB. And then the pharmacists, obviously, prior to having that nice, robust checklist, the pharmacists were the ones who are really looking at that. It depends. I guess I don't have a one answer for that. There's times when we've let it happen when it was a drug that it wasn't going to have a major financial impact on the organization, or we expected a small accrual. But there's one recently, actually, with Nivolumab and another expensive agent that would be off-label. And so I already have plans to be in touch with the company as that trial progresses, because it is not a sustainable thing for us to take on that much risk if the company isn't going to be offering to supply drugs. So when it's going to have a significant budgetary impact, we work with whoever our local sponsor, if it's not a PI here, work with the company to try to get replacement drugs. In many circumstances, unfortunately, it's going to be it's going to mean that we have to say no to the trial. But we really haven't seen a lot of that. We've been able to work through them.
Okay, great. All right, and I think this is going to be our last question before we wrap up. Niesha, does the James Cancer Center utilize 340B status?
No, we're currently not eligible.
Okay, great. Well, thank you, everyone. Thank you, Ms. Griffith, and thank you, Dr. McGivney, for both engaging presentations. I want to say thank you to our audience for participating. The webinar and slides will be available on our website, accc-iclio.org, shortly, and all registrants will also receive an email with the link. So we also hope you'll join us next Thursday, September 3rd, for our next webinar installment, which will focus on management best practices with Stephen D'Amato, who's Executive Director and Clinical Pharmacy Specialist at the New England Cancer Specialists, as well as the ACCC President and another ICLIO Advisory Committee member. We hope you enjoy the rest of your day, and thanks so much for joining us.